Hello, my name is Ryan, and welcome to the Melanoma Research Foundation Ask the Expert series. I am the Education Program Coordinator for the rare subtypes at the Melanoma Research Foundation. We're pleased to have you join us this evening for this educational opportunity titled Understanding Uveal Melanoma, Screening, Diagnosis, and Treatment Options. The focus of this webinar is a discussion about uveal melanoma and the importance of annual screenings. We'll also explore current diagnosis challenges, treatment options, and in development. Hear firsthand from Garth Corner from his experience with treatment, including the impact on his daily life and the importance of early intervention. At the conclusion of this discussion, there'll be an opportunity for attendees to ask questions to both Dr. Stacey and Garth. So I would really like to thank our sponsor, Aura Biosciences. We're really grateful for them for their generous support of this webinar and investment in the MRF's mission in helping to educate and support patients. I just want to share a little bit about the Melanoma Research Foundation. The MRF is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating research while educating to and advocating for the melanoma community. We know that education is critical for patients to make informed decisions about their care. We're so grateful for our speakers for joining us this evening. And I would just like to add, as we're talking about ocular melanoma, you are welcome to join the MRF's Eye on OM quarterly newsletter for the latest updates, insights, and resources on ocular melanoma. Stay informed about research, patient stories, events with the OM community, and you can do that on our website. Also, don't miss out on our Eyes on a Cure Patient and Caregiver Symposium. That is April 26th and April 27th in partnership with Cleveland Clinic, Cole Eye Institute. And this event really focuses on support education. So stay tuned for more details as we have registration opening at the beginning of the year. We know that education is critical for patients to make informed decisions about their care. We have many educational programs and offerings, and they're not only directed at patients, but we create educational materials and events for caregivers, family members, and providers. Our offerings include materials that are available for download and order for free, or you can order them. We also have webinars, animated patient videos, our patient and caregiver symposia series, and information on our other rare subtypes that includes OM, mucosal, cutaneous, pediatric, adolescent, and young adult. And so if you would like those, you can go to our website. There are many opportunities to support the work at MRF through a variety of programs, through events and research funding. We host events, our patient symposiums, and Miles for Melanoma 5Ks in cities all across the country. We hope you'll join us with one of those amazing events. If you're interested, reach out to education@melanoma.org to learn more about ways you can engage with the melanoma community while investing in our shared mission. And the best way to learn about the MRF, including information about our education, advocacy, or research programs, awareness campaigns, and any upcoming events, is to follow us on social media. And if you like this webinar, or if you know someone who wasn't able to make it tonight, this webinar will be available on our YouTube channel afterwards. And then lastly, I just want to thank our sponsor, Aura Biosciences, again for their support. We cannot do or put on educational events without their support. If you're interested in sponsoring a webinar, please reach out to education@melanoma.org. And then just lastly, again, a bit of housekeeping before we get started. We encourage you to use the Q&A box to ask questions throughout the session. We've already received some questions, which is wonderful. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed at your healthcare provider. We encourage everyone to visit melanoma.org to learn more about our resources that we have available. So we can get started. First, we'll hear from Dr. Stacey, and Dr. Stacey is an ocular oncologist at the University of Washington and Seattle Children's Hospital in Seattle, Washington. He cares for patients with ocular tumors inside and outside the eye. He completed his undergraduate and master's degree in statistics at Brigham Young University. He then returned to Ohio, where he grew up to complete medical school at The Ohio State University. His ophthalmology training was completed at the University of Michigan and completed his training in London, England, where he was a fellow in ocular oncology at Moorhead's Eye Hospital. His wonderful wife and 4 very busy children. We're honored to have you join us, Dr. Stacey. You can go ahead and share your slides.
Great, thank you so much. Okay, are these showing up the right way, Ryan? Great. So thank you so much for the invitation to be here, and thank you for organizing this. I recognize that talking about a disease that you or your family member has is not always easy, and I know there's many questions, so hopefully we'll have some time at the end for questions. I may not be able to answer them all today, but hopefully we can answer some of the most important ones. I'm going to talk today about some basics, where melanoma comes from, what is the biology of melanoma, how frequent do we see this melanoma, ocular melanoma, in the population, and then we'll talk about treatment options, staging, risk of spread, and some clinical trials that are upcoming and emerging and very exciting. For those of you who were signed up last month for this, I really do apologize that we had to reschedule. I am from Ohio, where we got many, many storms when I was growing up, but I've never seen a storm like the one that hit us. These are photos just from within a few hundred yards of my home. And on the day of the last, when we were supposed to have this symposium last month, I had to chainsaw my way out of my driveway, and there was no internet, and I had no power for about a week. So I apologize for the delay, but I'm glad that we could get it rescheduled today. I want to start just by talking about cancer in general. What is cancer? So cancer is a disease caused by uncontrolled division or replication of cells. We use the word cancer because of its Greek root. Cancer, you can think of those people who were born in July, think of themselves as cancers because the crab is their sign. The word cancer comes from the word crab because the blood vessels that grow to produce cancer and to supply blood flow to cancer looked to the early doctors like the legs of a crab. You may hear some other words used as well. Oncology is a word we often use. The word onc means mass, and oncology is the study of masses. Neoplasia is another word that you may hear, and that's just new growth or new tumor growth. All of these words really refer to the same thing, which is unregulated growth of cells. Now, in our body, we have cells in every organ and every system. What you may not realize is that throughout the day, thousands of our cells are undergoing changes that should not happen. Those changes occur because of mutation. Mutation changes the DNA within the cell, and mutations lead to cells becoming abnormal, or what you may hear as atypical. If the cell is just abnormal, nothing may necessarily happen. But if a mutation allows a cell to grow in an unregulated way, then you start to develop the precursors to what cancer is. Now, just unregulated growth is not cancer. Think of moles on our skin. Moles are cells that underwent some sort of a mutation that allowed them to grow in an unregulated way, but then they stopped growing, and they are not cancer because they stopped growing. In order to become cancer, the lesion or the tumor that has grown would have to undergo or receive some additional mutations that allow it to invade into the local structures and into the blood vessels. When you have invasion, then you have malignancy, or in other words, cancer. So the definition of cancer is mutation that allows unregulated growth in cells to invade. Further mutation beyond this allows those cells to get into the bloodstream and then get back out of the bloodstream into other parts of the body that lead to metastasis or spread throughout the rest of the body. There's various mechanisms that allow a cell to do this, but the important thing to remember is that this is happening all day, every day. Every time you walk out in the sun, many of the cells on your skin undergo some sort of a mutation, but our body is usually able to identify these mutations and stop them from becoming cancer. When cancer forms, it's because the tumor has hidden from the body. Now, we're going to talk about one specific cancer, which is melanoma inside of the eye. You will often hear this referred to as ocular melanoma, and I will refer to it as ocular melanoma because that's what we say colloquially, though it's not a really accurate term because there are other cancers of the eye that are not the cancer that we're talking about. The cancer we're talking about is, in its truest sense, called uveal melanoma, because it is housed in the uvea, or the middle layer of the eye. I'm not sure if you can see my cursor. Ryan, can you see my cursor moving? I can see your head. Good. Okay. The middle layer of the eye consists of the structures that are not on the outside and not on the inside of the eye. And it is this location where we have melanocytes, which are the cells that lead to melanoma. You can see here in colored description the middle layer of the eye, which includes the iris, which makes your pupil, the ciliary body, which is invisible. You can't see it because it's behind the iris, but this does a few things, including helping you focus. And then the choroid, which is the blood vessel layer that supplies and supports the retina in the back of the eye. This is where the cells that produce melanoma are housed. And so when we refer to ocular melanoma, we're really referring to melanoma of these structures in the uvea. We don't really know exactly why these cells are even in the eye. Melanocytes are typically housed in the body to help protect the body from the damaging rays of sunlight and other radiation. That's most likely the reason they're in the eye, but they're also in places in the eye that don't usually get sunlight, and so we don't know exactly why they're there. We just know that they're there and that they can undergo a change. So, how does the change occur in the eye? Well, it's very simple. It goes back to that initial flow chart. Mutation. Mutation is what causes melanoma in the eye to form. There are a few known driver mutations, or genes that when there is a mutation in this gene, it leads to melanoma, but we don't know all of them. Melanoma in the eye is relatively rare. It only represents about 5% of all melanomas, but it is the second most common form of melanoma. It occurs most often in individuals with lighter skin tones. I practice in Washington, and so it ends up representing about 50 people per year in Washington, or about 150 people per year in the Pacific Northwest. We don't know exactly what causes it. We just, like I said, know that it occurs. Diagnosing melanoma in the eye is not as simple as diagnosing melanoma on the skin. If you have a funny lesion on your skin, you go to the dermatologist and they cut it out. That's not really possible in the eye. Remember, the eyeball, most people don't realize this, the eyeball is hollow. It has a hard outer shell, and then it's full of fluid. It's like a basketball. I can't take a piece out of a basketball and then give that ball to my son and say, go play basketball. It's the same with the eye. I can't cut a piece of the eye out to figure out if the lesion that I'm worried about is a melanoma or not. For this reason, the gold standard, or the best way to diagnose a melanoma in the eye, is not actually a biopsy. It's a doctor looking at the lesion. To my knowledge, it's the only malignant cancer, or the eye contains the only malignant cancers, where the diagnosis is simply made by looking at the lesion. There are various things we can do to biopsy a lesion, including using a needle, and I won't go into the effects, but it's not a perfect solution either. Using a needle is a surrogate, but not a perfect solution for diagnosis. So we have to rely on how things look inside the eye when the patient comes to clinic. And so I'm going to talk a little bit about that. Melanoma in the eye usually comes from a mole, or what in medical terms is referred to as a nevus. Most of us have moles on our skin. About 10% of us have moles inside of our eye, and usually these moles don't cause any problems. They don't grow and they don't change, but occasionally they can grow and they can change. This is the reason why if you have a mole, it's something that just needs to be monitored. If moles in the eye change, you probably aren't going to notice them change until very late in the process. And so you need to have an annual exam, dilation, by somebody who knows what they're looking at to evaluate the mole and make sure that it's not getting any bigger. Here are some examples of how moles can change. You can see here on the left, these are the same lesion. Just on the left was the initial image, and on the right, the lesion grew with a little nodule on its surface. In this pattern, the lesion on the left was flat, and the lesion grew also in a flat form. There was really no thickness here. It just started to grow down into that little finger projection that you can see. Here is a mole on the left that looked old. It had been there for a long time. But on the right, you can see that the mole grew in all axes. And here's a mole way off on the side that unfortunately grew in a little finger-like projection as well. These are examples of moles that we were monitoring that ended up growing. It's a good illustration of why we have to monitor moles in the eye. Now I'm going to talk briefly about the 3 locations where you can get a melanoma in the uvea, or an ocular melanoma. The first is the iris. That's the external part of the uvea, the one that we can see. It's very rare to develop a melanoma in the iris, and of all of the 3 places to get a melanoma, usually this is the place that you would want if you could choose, because for some reason that we don't have a great explanation for, melanomas in the iris very rarely spread to the rest of the body. They can, but very rarely. They're treated the same way other melanomas in the eye are treated, and that's with radiation, and we'll talk about that in a minute. The second location as we move further back is in the ciliary body. The ciliary body, unfortunately, can hide. It may not be visible to the patient nor to the doctor until late in the game. Here you see some examples of the ciliary body growing to a point where it's actually starting to grow through the wall of the eye and grow into the iris of the eye. Sometimes when the ciliary body melanoma is large enough, we can see it poking out through the pupil of the eye as well. But again, sometimes it can hide. The final place is the choroid, or that blood vessel layer in the back of the eye. Here is a lesion initially, and a lesion, the same lesion as it grew. The choroid is the most common location for melanoma, most likely because it's also the most prevalent space. It takes up the most real estate in the eye in terms of uveal real estate. Determining what a melanoma is and what is just a mole that is concerning is challenging. And this is the work of an ocular oncologist. This is why we go to years and years of training specifically for this question. Because biopsy is not perfectly reliable in any form, we have to rely on what we call risk stratification. So we look at various entities inside of the mole and around the eye that help us determine if this thing is higher risk or lower risk of growing and becoming a melanoma that can spread. You've probably heard of some of these, but I'm just going to highlight the most important risk factors that we look for. Probably the most important thing we look for is thickness. The thickness of a lesion in the eye helps us determine what the risk is, both of becoming a melanoma and of spreading. We determine the thickness with some sort of an ultrasound scan. You can see here on the right is an ultrasound scan showing me the thickness of this lesion right here. There is no perfect cutoff, but once you get close to 2 or 3 millimeters thick, that's when we start to be very concerned. Now, you can have a melanoma that's less than that, for sure. But once you get to 2 or 3 millimeters thick, not many of those lesions are not melanomas. We look for a type of pigmentation called lipofuscin. I say some things in the British way. In Britain, they say lipofuscin because I trained there, but you probably hear lipofuscin. Lipofuscin is this orange pigmentation that you can see here inside of the pigmented nevus. That's a sign of activity within the lesion and a sign that this is probably making some sort of concerning change inside of the mole. We also look for fluid between the retina and the choroid. What we do here for these images is we take a slice through this lesion, almost like we're taking a slice through a hamburger and looking at the different layers of the hamburger. This is how it should look. But you can see as you take this slice out, this area is thickened. That is the lesion or the nevus. And then there's fluid between the lesion and the overlying retina here. That's a sign of fluid or another sign of activity within the lesion. All of those things help us determine what is and is not a melanoma, but I'll tell you that that is not an easy job, and it's not an easy job even for very well-trained ophthalmologists. And that's why somebody with a training in ocular oncology is usually the person who's making these diagnoses. Here's some photos, all of which were sent to us or representative of things that are sent to us out of concern that they are melanoma. But only one of them is a melanoma, and it's the one that you may think is least likely to be a melanoma. It's this one in the middle that looks completely pale and not pigmented. The ones that look pigmented, which were concerning for melanomas, ended up not being melanomas, but what we call masquerades, things that look like melanomas. Now, the problem with a melanoma in the eye is twofold. If you leave a melanoma untreated, two things will happen. The first is that it will grow inside of the eye and destroy the eye and the vision. The second is that it can spread. The larger the tumor, the higher the risk of the spread in general terms. If you don't do anything, this is what happens. This is a patient who did not want treatment, and the melanoma grew and grew until there was no vision left in the eye. For this reason, we recommend treatment in most cases where we diagnose melanoma, but as you'll see, maybe not all cases. There's a few treatments that can be provided. One of them is surveillance or watching. Then there are laser treatments, radiation, and surgery. And let me just take a step to the side here and say, one thing that I notice a lot in patient communities is the way you've been treated and the way you've heard things explained seems very black and white. And I will tell you that it's not all black and white. What treatment is delivered and at what point the treatment is delivered is very much debatable. It's something that I debate and with all of my colleagues across the world at all of our meetings. We don't know the answer all of the time. We're going to talk about what to do if you have a high-risk lesion or if you have complications from radiation, what type of biopsy to obtain. There's a lot of strong feelings that things need to be done a certain way, and I just ask you to take a step back and think that, or realize that there really aren't perfect answers to most of these questions. And so having some ability to recognize that there's a number of different ways to do something, I think is very healthy for the community at large. I'm going to talk about some treatment options here. One person could walk into 3 different centers and be offered a different treatment option at each center. And let me just tell you, it's okay. It's going to be okay. Most of the treatment options are going to leave you with the same outcome in the eye. We don't have perfect answers for rare diseases like this. I'm going to start with surveillance. So it seems strange to not do anything when you diagnose a melanoma, but there are reasons for that. It's important to recognize that treatment, particularly with radiation, of a melanoma that's close to the center of the back of the eye or close to the nerve of the eye will almost certainly lead to significant vision loss, if not loss of all the useful central vision. If you could put that treatment off for a few years and not risk spread to the rest of the body that much, it might make sense. Now, we don't know exactly how much we would risk. Let's say this lesion comes in. This is a very small lesion, less than 1 millimeter thick. What is the risk of waiting 2 or 3 years before doing radiation? Well, I can't tell you exactly, but I can tell you that it's pretty small. That risk is quite small. And in some countries, they would not treat this. And in some centers in the United States, they would not treat this. So it's a reasonable discussion for any small lesion, particularly any small lesion around the visual part of the eye, and particularly in patients who are older or not as healthy, where surgery and radiation might make things much worse for them and their body. There are some treatments available that would fit under a laser category. None of these are what we would consider the gold standard. Most of them provide some ability to control the tumor with far less side effects to the vision. But in all situations, the risk that the tumor continues to grow is higher with laser than it is with radiation. So sometimes we use laser, and we use it for lesions, again, just like when we're surveilling or observing lesions, we're using them for lesions that are small or they're close to the nerve of the eye where radiation would necessarily destroy the vision. Here's a lesion that was treated with photodynamic therapy, which is a type of cold laser, where we got a really good response, and it's lasted for a number of years. Now, it may grow again in 5 or 6 years, but that bought us some time before moving to radiation. Most patients in the United States and across the world who have uveal melanoma or ocular melanoma are treated with radiation. And there's a few ways to deliver the radiation. The most commonly used way is called plaque brachytherapy. And that's where a device about the size of a quarter is impregnated with some radioactive seeds. And that device is sutured or stitched onto the outside wall of the eye directly opposite the melanoma. It's left there for about a week, and during that week, the radiation destroys the melanoma. There are a few different forms of radioactive plaques. This is one called iodine. This is one called ruthenium. And there are other ones like palladium. All of them do the same thing, which is destroy the melanoma with radioactive seeds. Proton beam is an external source of radiation that delivers the radiation almost like a ray gun or a cannon. This is only available in about 4 or 5 centers in the United States, though that number is increasing, and so more patients will likely be receiving this. Proton beam allows for delivery specifically and very accurately into the area of the melanoma. Most data would suggest that proton beam might provide a little bit better ability to control the tumor, but it might have a little bit worse side effects to the vision. All of them are good and good options. Here's an example of what radiation can do to that melanoma we looked at before. It can shrink it down and scar it down. Sometimes the lesions are just too big for radiation. So radiation would probably lead to a death of the eye or pain. In those situations, we would recommend eye removal surgery as the first line or the primary treatment. It's a very good treatment because it gives you a very low risk of ever having the melanoma come back in the eye socket. And in the end, most patients don't regret having their eye removed. We do a really good job at getting prosthetics that can fool just about everybody other than close family and friends. I want to talk just briefly about staging. We stage melanomas in 2 ways, one by the clinical size and one by the DNA or the molecular signature. T1 is a small melanoma, a T2 a little bit larger, T3 even larger, and T4 is one that encompasses a large part of the eye and is pretty high risk. Staging is used to help us determine which lesions are highest risk for spread. You've heard a lot about biopsy, and biopsy is another way that we can determine what is higher risk for spread. To do the biopsy, what we do is we place a needle into the eye, either through the wall of the eye or through the inside of the eye, coming through here to biopsy something in the back of the eye, this is a picture of a needle going into the eye and biopsying something in the back of the eye. The molecular prognosis, or the results of the needle biopsy, can also help us determine if something is higher or lower risk for spread. Now, I want to just mention briefly life after treatment. I'll explain what these weird images look like in just a minute. There is no set standard on what should be done after treatment. This is a source of some anxiety to patients, especially when they talk to other patients, because their friend or the person they met is getting a different scan protocol. There is no standard protocol, and there's just not great data to know what the best idea is. Scanxiety, as we refer to it, is real, and some patients really are nervous leading up to their scans, and it's something that people have to deal with. I'm happy to answer questions afterwards if I can about scan protocols, but again, there's just not great information on it. It's important for everybody who has a melanoma to obtain surveillance inside of the eye to make sure that there's no regrowth or recurrence, and surveillance of the rest of the body up to some point. And what that point is something usually determined by an oncologist. How to cope with melanoma after your diagnosis is a tough topic. I'm not an expert here. Here's what I know. Ocular melanoma does not define you. And I asked ChatGPT to give me a picture of what it looks like for ocular melanoma to not define you, and I got this image right here. And then I asked ChatGPT, what does it look like to thrive with a diagnosis of cancer after treatment? And I got this image right here. So I'm not an expert here, but the one take-home message here from the eye doctor, from the ocular oncologist, is you're not defined by this. You are defined by so many other things. I want to touch briefly on some of the emerging treatments that are very exciting. Now, I want to state that I have no financial relationship with any of these companies. So I'm excited about each of them, and I am not part of any of the companies. ARA has developed a treatment potentially for small melanomas. They're in a phase 3 clinical trial, which means we think that we've found a dose that works, and we're now trying it on a lot of patients. And they're hoping to treat 100 patients across the globe. We are enrolling patients in Seattle right now, as are most places across the world. What we're hoping is that the treatment shrinks the tumor down and prevents the patient from needing radiation. The way it works is the patient gets an injection into the eye of a particle that's activated by light. And then a laser beam is shown into the eye at the melanoma, and the laser beam activates the chemical inside of the tumor. The initial data are promising, and we're all hopeful that this is something that's going to be able to be used for small tumors rather than radiation. I'll touch just very briefly on a new medication called Daro. We all refer to it as Daro, darovasertib. This is a medication that blocks the pathway where most ocular melanomas develop. Now, all we know about this is that it has a pretty good ability to shrink tumors down. And so the current clinical trial for Daro is actually taking very large tumors that are not amenable to radiation and shrinking them down so that they can be radiated rather than removing the eye. We have a lot to learn about this medication, but it's exciting. After radiation, as many of you know, there are a lot of side effects from radiation to the visual part of the eye. There is currently a clinical trial organized through the DRCR, which is a national organization in the United States, to try and determine if medications injected into the eye shortly after radiation can help prevent the worst of the damage from radiation. This is a trial open at many centers. It's opening in our center as well. And it's also something we're excited about. Hopefully we can find something that helps prevent the worst of the damage after radiation. As many of you have heard, there are some great new medications in the field of metastatic disease once it has spread. Ocular melanoma, though a small field, was recently published in the most important clinical medical journal in the world, New England Journal of Medicine, where tebentafusp, or what we refer to as TEBI, was shown to prevent or to prolong survival in patients who had spread to the liver. The prolongation is not enormous, but it's very exciting, and many of our patients here in Seattle are using this medication now. There's a second medication also approved for metastatic disease, which is called Hepzato, which is an infusion of a chemotherapy into the liver. So this is done by an interventional radiologist. They put a port into the liver and they infuse the medication into the liver, and it has a very good ability of treating the tumors in the liver. We are at a really exciting time in melanoma. In uveal melanoma. When I started, which was not that long ago, none of these new things were available. There were no approved treatments for metastatic disease. There was no good treatment for small melanomas other than radiation. We didn't know if we could stop radiation retinopathy. All of these things are looking better and better, but we're still at the early days. Clinical trials are very important. I would encourage people to enroll in clinical trials, whatever that means. There's various forms of clinical trials. It doesn't necessarily mean that you need to take a medication, but clinical trials are the way that we are moving this dial forward. The future is bright. I won't go into this, but all of these things on this slide are things that we've learned in the past 10 years about uveal melanoma. So we are just at the beginning of what I think is going to be many, many new treatment options for this disease. Thank you guys so much for your time. This is my family. I'm so grateful for them and for their support of me as well. And I thank you. I'll take questions after Garth is done with his talk.
Thank you so much, Dr. Stacey. That was a great presentation. And I bet you could talk for hours about all the new things happening, the really great things that are going on. Next, we'll hear from Garth Corner. Garth is a dedicated professional with a diverse background in military service, law enforcement, and entrepreneurship. He served in the U.S. Army from 1989 to 2010, retiring as a first sergeant after completing 3 combat deployments to Iraq. Following his military career, he joined the Kent Police Department in Kent, Washington, where he's been serving as a patrol officer. In recognition of his service, he was honored as Officer of the Year in 2020. So with a unique blend of leadership experience and commitment to community service, he continues to make a significant impact in his personal and professional endeavors. And so, Garth, thank you for being here as a patient, and looking forward to hearing your story.
Thank you. I appreciate the invitation. Just glad to be here. So my introduction to ocular melanoma started in 2019. Can you guys hear me? When I started to have a blurry spot in my vision in my left eye. So if you can imagine whatever you're trying to focus on, it'd be blurry in that particular spot, almost like trying to look through an opaque shower curtain. Whereas the rest of the vision in the peripheral area was still perfectly fine. So it was kind of strange, just my left eye. Being well into my 40s, I kind of just initially brushed it off as being that age where I probably needed to start getting glasses. Had perfect vision before that, good health, so never had a reason to be concerned about anything else. So I did initially go to the ophthalmologist right away, just from being in that military culture and law enforcement. Sometimes going to see the doctor can be stigmatizing, your condition, just to, tough it out, walk it off, and it'll be fine. But obviously this is something that you can't do that. It's not really a good treatment plan. So eventually I did go to see my local lens crafters, where he did the dilated eye exam that Dr. Stacey talked about. And he started asking me some strange questions about, am I seeing floaters in my eye, or am I seeing flashes of light? Where I had no idea what he was talking about, but later on when I did a deep dive into Google, I understood clearly that, this is a little bit more serious. But he did some imaging and asked me those questions. He probably had some suspicions, but wasn't confident. I didn't think he wanted to tell me, use the C word, so he referred me to eventually Dr. Stacey. And to know him, with how hard it is to get a routine appointment with him so many months out, to get an appointment within a few weeks, should have been a reason for concern. I didn't really know that at the time, but eventually got in to see Dr. Stacey, and he did his imaging and took a look at the scans and everything that he did and had that awkward conversation where he says, yeah, this is cancer. So really a shock. Didn't realize you could ever get cancer of the eye. So for me, I always relied on good health. That was always something that happened to other people. So it was kind of really a big initial shock to get over after that first diagnosis with Dr. Stacey in his office. So after that, it was kind of a whirlwind of consultations, exams, more paperwork to fill out, imaging. Got to meet the staff at the Proton Center that Dr. Stacey talked about in Seattle. So being fortunate to be close to that, that was the option that I decided to go with. And then so received the proton radiation treatment a few months after the first diagnosis. It's not very invasive. It's not like you would imagine with chemotherapy where it wipes you out for weeks at a time. It's not very invasive or debilitating at all. I think I was back to work the next week. After that, it was kind of just business as usual. I was back to work. Didn't really lose a lot of capability in my daily activities. Eventually, my eyesight just started to be affected a little bit more from the radiation, starting to get more blurry into the outer edges of the eye. Early intervention was only possible in my case because of where the tumor presented itself near the optic nerve. Some of those graphics that Dr. Stacey showed, the web of blood vessels with the tumor right next to it, that's kind of where mine was, where it started to affect my vision early on. So the tumor was a little bit on the small side. Had it been in the outer edges of the eye where it would not have affected my eyesight that soon, I would have never had a reason to go to the eye doctor and kind of get an exam. It would have just kept growing. And then the outcome could have been a lot worse. So while it affected my vision a lot sooner, it helped me kind of get moving with getting an exam and finding out what was going on. As far as after many sleepless nights and a lot of research and kind of imagining the worst case scenario, you get to a point where it's time to get back with your normal routine. I wanted to get back to work. Your family relies on you to kind of, you still need to be a dad, husband, and still go about your daily life. For me, that was kind of the best way to stay engaged with my normal life and to get back to my normal routine, which has fortunately been possible. With the metastasis, the thing, you never know when it could pop up somewhere else in your liver, usually, or possibly your lungs. I think the kind of number is like 50%. Fortunately, with Dr. Stacey, he did the biopsy before I had my radiation treatment and was able to get some genetic testing done, and which put me in kind of a lower category of risk. Still, it's not zero. It can come up again later on, so it's nothing is guaranteed, but so that's kind of where I'm at this point. Still doing okay, my normal routine, and hopefully the advancements that Dr. Stacey had talked about, confident we'll see a cure sooner than later.
Thanks, Garth. I appreciate you sharing. And I think it's always great to have patients on to share their story, and especially since you and Dr. Stacey, you see Dr. Stacey. I think the relationship is super important to have a good relationship with your healthcare provider. And so with that, I will start with some questions that people had sent to me. So I guess you can start with someone had mentioned information about genetic testing, as this person had mentioned their grandfather and their uncle and themselves. There's 3 generations who are diagnosed with ocular melanoma. And so I think the question is wondering if there's new information and other available testing that they can do, since they are the 3rd generation in their family. And so I guess I'll let Dr. Stacey talk about that.
Yeah, that's a great question. Important to distinguish two terms here. One is genetic and one is familial. So this patient has a family history of ocular melanoma. And oftentimes we talk about genetic testing, like Garth talked about his genetic testing. Genetic does not mean familial. So we get genetic testing of the tumor. We can find different mutations in the tumor. It can tell us about that tumor, but it doesn't tell us about the whole body. This patient, it sounds like they have what's called a cancer predisposition syndrome, or some sort of a mutation that's being passed through the family that increases their risk of ocular melanoma. That is extremely rare. It's probably about 1% of all patients with ocular melanoma. And I want to say, anybody who's listening to this, if you don't have a family history of somebody else with ocular melanoma, then don't let this worry you. This is not of your concern. When we worry about people who have familial ocular melanoma, it's people who have others in their family who have had ocular melanoma. We don't know all of the mutations that can cause this, but it sounds like in this family there is a mutation. There are a couple of centers in the United States doing research on this. We are doing some ourselves. There's a center at Ohio State that has really formalized the familial uveal melanoma syndromes. If this patient was interested at some point, Ryan, maybe you could get them in touch with me and I could help them find some clinical trials to be part of. Even if they found, or even if you enrolled, it doesn't mean that we'll find the mutation. These can be hard to find, even though we expect that there is one.
Thank you, Dr. Stacey. Let's see. Garth, how did you communicate your concerns and needs with your healthcare team, and what advice would you give to other patients?
I would say I was fortunate to be connected soon with Dr. Stacey, who was well regarded as subject matter expert, leading researcher, expert on this type of disease, and being close by him. So in that respect, very fortunate. I would say just and he deals with a lot of patients with this disease. They fly in from neighboring states to see him, so he has a lot of depth of experience with talking to his patients. And what I like about what his style of care is, he'll provide all of the options to you as a patient, give his recommendations, but ultimately leave the decision up to you as the patient, which is great. And being very direct about what the prognosis is, what your options are, the likely outcomes, but doesn't make any guarantees that he can't make. So as a patient, I really appreciated that. So I would say as a patient, just to make sure that you do your research into your physician, your healthcare team, and make sure all of your questions are answered, and all the options that are discussed are available to you, that you kind of make the decision that's best for you. There's also a lot of patient groups out there on social media that you can latch onto, and there's a depth of knowledge with those as well that you can tap into. Normally patients that it's hard to relate to in a rare disease like this with people, because they don't really understand. You don't either when you first are diagnosed. So to connect with people that know about it is really beneficial as well.
Thanks, Garth. Dr. Stacey, someone had asked, can you speak more of risk of metastasis? I see conflicting information. Some sites state 50% risk, but some experts I've heard state it's more dependent on tumor size. Also, should metastatic surveillance continue past 5 years from primary tumor treatment?
Great questions. I think both of those statements are accurate. The data appear to show that about 40 to 50% of patients will develop metastatic disease. That's over extended follow-up, 10 plus years of follow-up. It's also true that your risk of metastasis is dependent on a couple of factors. So a larger tumor does have a higher risk. It doesn't mean that the 50% number isn't true. The 50% number is true for all, but we can compartmentalize and with the size of the tumor and also the prognostic biopsy, we can get a little bit more specific about what somebody's risk might be. But there is no absolute. So what I don't want you to do is to look at your results if you have the gene expression profile or if you have a really large tumor. I don't want you to think that you know the answer. You may not. In both sides, a large tumor with high risk biology from a biopsy, it doesn't mean that it necessarily will spread. And a small tumor with low risk pathology, it doesn't mean that it necessarily won't spread. There is a risk stratification, but it's not perfect. In terms of scanning, I'll go back to what I said. There is no golden rule here. We just simply don't know. And so if you went to ask 10 different centers, you would get 10 different answers. And that's not because they don't know what they're talking about. It's because we don't have great data. And so people are making the best decisions they can with imperfect data. In some situations in our center, we will stop scans at 5 years. In some situations, we never recommend stopping scans. And we use risk stratification for that. But somebody could come to me and say, oh, I have a small tumor and somebody told me to scan the rest of my life. And I would say, yeah, there's an argument for that. So just know that there's no perfect science here. And scanxiety is real. And if your doctors are talking to you about decreasing the scan interval, if you can do it, it may not be a bad thing for you and for your life.
Thank you, Dr. Stacey. Another question. I read the article by ICF that talks about the risk of metastatic with delaying treatment of OM. I was wondering if the age of nevus has an increased risk for metastasis.
Yeah, you got to be very careful making conclusions about delaying things. This is a big debate in my field right now. There have been some recent scientific articles suggesting that a delay in treatment will increase the risk of metastasis. And there have been some rebuttal papers, myself writing one included, to say you need to be careful with the way that you are analyzing the data, because what you're saying is not entirely accurate and people are going to make incorrect conclusions. Here's what we know. What we know is that the larger a tumor is, the higher the risk of metastasis. Here's what we also know. The molecular findings or the mutations in the melanoma also affect the risk of spread. What we don't know is when those molecular changes happen. If you are a class 1 when it's small, are you always going to be a class 1? Or could you become a class 2? If you're low risk when you're small, are you going to become higher risk when you're larger? We don't know that. And so when a patient comes into my office with a tumor, here's what I know. Another thing that I know. I could remove their eye that day. It's very simple. I could take them to the operating room and that day remove their eye. Or I could take a few months, few weeks, couple months to prepare a radiation treatment to do our very best to destroy the melanoma, but preserve what we can of the vision in the eye. What we absolutely know is that in no clinical trial has there ever been a difference in the risk of spread between those two groups. So you may hear a lot of things and people may write a lot of things, but what we absolutely know is that in those two groups, there's never been a difference in a clinical trial between the risk of spread. That's why we don't just remove everybody's eye when we diagnose them with melanoma. We know that we can take a few months to prepare, or a few weeks to prepare a treatment, and then it may take 4 to 6 weeks to get the radiation done. We've never seen that that increases the risk to the rest of the body. So if that's true, then it's hard to say the words that this question asker asked, which is, a delay in care increases the risk of spread. Well, I don't know that you can say that. A delay of years, maybe, but a delay of weeks or months, we've never been able to show that. And if there is a difference, it's going to be very, very small. So we don't, I have a mole here on my face. That mole could become melanoma. And I could decrease the risk of melanoma and spread of melanoma if I remove all of the skin on the right side of my face. But I'm not going to do that, even though it would decrease the risk, because that thing could become melanoma and could spread. But I'm not going to do it because it doesn't make sense. In the same way, I'm not going to treat every mole in the eye with radiation and destroy everybody's vision, because some of those moles might become melanoma in the future. So there's a lot of gray area here. There's no absolutes. It's not black and white. What it requires is what Garth spoke about. Your doctor needs to explain to you what the risks of treatment and the risks of waiting are, and what the different treatments options are, and help you to the best of their ability understand that, and then help you make a decision. But there's no black and white, absolute, definite answers in this disease.
Thank you, Dr. Stacey. I'm looking at the time. There's many more questions, but I'll kind of end on this question for the both of you. What is one key message you hope attendees take away from today's session about uveal melanoma and the importance of screening or dilated eye exams? So what is the key message you hope that they take away from this?
Garth, you want to go?
Yeah, I just say for prevention, that dilated eye exam is so important, especially those of us like me who never kind of needed glasses before and had no reason to go to an ophthalmologist. You can convince one person to go get an dilated eye exam. That would be terrific to get more people aware of that because of how rare this cancer is.
And I would add, dilated eye exams are very easy to get, so very low risk, just a few minutes. So that's certainly a good idea. The takeaway I would say from today is I try to help the patients that come into clinic realize that the future is bright. It's okay. It's going to be okay. We have things are growing and changing, and if you had gotten into this disease yourself, if you had been diagnosed 20 years ago, you'd be in a very different place than being diagnosed now. So it's an exciting time to be part of this community, and the future is bright. I would just leave it at that.
Thank you both. So I just want to kind of end on with that. I would just like to again thank you guys for joining us today, and especially our speakers for presenting during our Ask the Expert session. We appreciate all that you do for the community and appreciate you taking additional time to be with us. Another thanks to Aura Biosciences for their generous support and of our Ask the Expert webinar series. And again, this program will be available on our YouTube channel in a few weeks. So at the end of the program, when you close your screen, there'll be a short evaluation that'll pop up in your browser. Please fill that out. It provides us with feedback on today's session and helps us create new programs for the future. And like I mentioned, there were so many questions we didn't get to. And so I hope that we can do another Ask the Expert about this so that we can continue to share and do Ask the Experts that everybody would like in the community. So please visit melanoma.org to learn more about our upcoming webinars and our other educational or advocacy opportunities. We have a ton of free resources that we offer to patients, caregivers, and healthcare providers. That includes educational literature, patient forum, Ask the Nurse, and animated patient video series. So if you have any questions that you can think of later, please email us at education@melanoma.org. And I just want to thank you all again for joining us this evening. I hope that everyone has a good rest of their night.